get through without exemption. When I bit off more than I could chew, but
a meeting on T-cell lymphomas with a whole group of nationally known transplanters. There's a meeting this weekend going on in Bologna in Italy on T-cell lymphomas. So there is never a day when there is not a group of experts getting together and learning more from each other about where we are with lymphoma. I think I would like to turn over to our speakers now and start with Dr. Brad Kahl. Brad, I've known for many years. He has just blossomed so very quickly from finishing his fellowship at the University of Wisconsin to becoming the lead member of the lymphoma group at the Eastern Cooperative Oncology Group. He's collaborating with the other groups in the United States, and many, many new protocols have come out in lymphoma. Now, I know that there are many of my patients here today who do not have follicular lymphoma. You saw the program, you have lymphoma. I don't want you to think that you cannot ask questions about your lymphoma. If you have a low-grade lymphoma, what we're saying today about follicular lymphoma applies to all of you. If you have a more aggressive lymphoma or a Hodgkin lymphoma, many of the drugs that we're going to talk about today will have the ability to work in those diseases. So please, please, this is your meeting. We want you to ask questions. Brad, please come on up. Dr. Kahl is an expert known for the RESORT trial. I hope he tells you a little bit about this. The question of how we treat follicular lymphoma patients. You must understand that you either have low tumor burden, high tumor burden. Most of you have advanced stage disease. Many of you will not need treatment. Dr. Kahl's study actually was looking at early treatment in patients with follicular lymphoma who had a low tumor burden, and then actually putting them on a maintenance for 2 years versus waiting to retreat them when they actually relapsed. And you're going to hear about some of this. Many of you have questions about, should I be on Rituxan maintenance? Should I not be treated? And I hope Dr. Kahl's going to answer some of those questions. So it's my pleasure now to turn the first topic over to Dr. Kahl. Brad, welcome.
Thank you, Stephanie. A great pleasure to be here. I always enjoy coming down to Chicago from Madison, especially after a Packer victory. Actually, I was in clinic on Monday, which was the day after the Packers were manhandled by the 49ers, and the Bears had really looked impressive. And I have a few patients who come from Northern Illinois to see me, and 2 of the patients are huge Bear fans, and boy, did they give it to me in clinic that day. So I was feeling a lot better on Friday. So let me update you on low tumor burden follicular lymphoma. But before I do that, I'm going to spend a few minutes just talking about follicular lymphoma in general terms. Follicular lymphoma is in the category of non-Hodgkin's lymphoma that we consider indolent. So indolent refers to the natural history of the lymphoma. These tend to be slow-moving cancers. They generally are not curable with the drugs we have in 2012, but they're very readily treatable, and the prognosis is relatively good for all of these groups of lymphomas. So this is the listing of the lymphomas that we consider to be indolent. This would include follicular, small lymphocytic lymphoma, something called marginal zone lymphoma. There's a nodal version, there's a splenic version, and there's something called malt lymphoma. All the things I'm going to say today, which are focusing on follicular, you could really apply to these other lymphomas. So here's a pie graph showing frequency distribution of the different kinds of lymphomas. So there are lots of different kinds of lymphomas, and they all have their uniqueness. Follicular lymphoma makes up about 25% of new lymphomas in North America. So follicular is the second most common kind of non-Hodgkin's. It's typically advanced stage at presentation, and I'll get into the staging in a second. The reason is that patients are often asymptomatic for a long time. So you could walk around for years, quite honestly, with this lymphoma, not knowing you have it, because it doesn't give symptoms. There's no reason to go to the doctor if you feel perfect. And so often by the time it's diagnosed, it's very widespread in the body. That's typical for follicular lymphoma. It's hard to know what to tell people who are diagnosed now, what the average survival is. That's why I said 12 plus years. We don't really know. We know that it's a moving target. And there's data now indicating that patients diagnosed in the last few years clearly live longer than patients who were diagnosed 15 and 20 years ago. So we know we're making progress and that the outcomes are improving each year. I mentioned about the unhappy property of generally not being curable. It's hard to know if people are cured or not with this disease because the natural history is so long. And I avoid using the cure word with patients, and that's not to be negative, but I've seen patients who've had to come back after 10 and 15 and 20 years. So it's hard to know if anyone is ever cured with this thing. So I like to use other words when we're describing how we manage this kind of lymphoma. Follicular lymphoma can transform to a more aggressive version of lymphoma. That's called transformation. And that happens at a rate of about 3% per year, although the risk tends to diminish over time. But when transformation occurs, we then have to treat the lymphoma as an aggressive lymphoma. To diagnose follicular lymphoma, there are some things we can do. We can look at what proteins are expressed on the surface of the cell. So this is this term called immunophenotype. This stuff, CD10, CD19, CD22, that just tells us some of the different proteins that are sticking outside the tumor cells, and we can measure these things. Cytogenetics refers to how the DNA is rearranged inside the tumor cells. And most cases of follicular lymphoma have a specific DNA alteration. We call it a translocation. So a piece of DNA gets moved from chromosome 14 to 18 and vice versa. They flip-flop. And the result is you get overexpression of a certain gene. The gene is called BCL2, which results in overexpression of a certain protein called BCL2. And that sends a signal to those cancer cells that says, don't die. So the cells, they're not proliferating all that rapidly, but they accumulate. So this BCL2 overexpression is very central and key to the underlying biology of follicular lymphoma. Grading is a term that sometimes confuses people. That's different than staging. Grading is what we see when we look at the tumor cells under the microscope. So most of follicular lymphoma cells are what we consider small, but occasionally you see big cells intermixed amongst the small cells. And the more big cells there are, the higher the grade. So here are the criteria. If it's 1 to 5, it's grade 1. If it's 6 to 15 large cells, it's grade 2. And we lump those two together now in pathology reports. So it'll say grade 1-2. We just lump those two groups together. Most follicular lymphoma patients have grade 1-2. Maybe 15%, 20% have grade 3, which means there's more than 15 large cells in each field that you're looking at under the microscope. And then the grade 3 is further subdivided into 3A and 3B. 3B means it's just sheets of large cells. It's all you see are large cells. And if we see a grade 3B patient, we generally treat them like an aggressive lymphoma. The 3As are a little controversial. Should they be treated like the aggressive lymphomas, or can they be treated more like the grade 1, grade 2s? I don't think anybody really knows the answer to that, and different physicians will approach that entity in different ways. So staging refers to where the cancer is located in the body. Stage 1 is the cancer is just in one lymph node group. Stage 2 is it's in 2 or more, but on one side of the diaphragm or the other. Stage 3 means that the cancer is above and below the diaphragm. And stage 4 means the disease is in lymph nodes and also outside of lymph nodes, like lymph nodes plus bone marrow. Staging was developed for Hodgkin lymphoma and then applied to non-Hodgkin's. And I'll be honest, the staging in follicular, it's not the most important thing. People get really focused on their stage, and don't do that. Most people are stage 3 and stage 4 and have an excellent prognosis. So the stage of follicular lymphoma is not the most important thing. When we diagnose a patient with follicular lymphoma, usually they present with a lump, a swollen enlarged lymph node. And to make an accurate diagnosis, you need an adequate biopsy. And an adequate biopsy means you need a chunk. You need a lot to look at under the microscope. And probably Stephanie will attest to this. One of the most common situations we see are people have had teeny tiny biopsies and the pathology report is really squirrely and you're just not sure what you're dealing with. And we often send people back for more tissue because we want to know exactly what you have before we make important decisions about how best to manage your disease. So you need adequate tissue. And then we can do all sorts of fancy things with the biopsy, immunophenotyping, where you look at what kind of proteins are on the surface. We can look at the genetic alterations inside the cells. And with adequate tissue and with immunophenotyping and cytogenetics, we can figure out what people have. Once we figure out what they have, we do this thing called the staging evaluation, which is a physical examination and a history. Do you have symptoms? If yes, what are they? We do some blood work to look at how the critical organs are working, the liver, the kidneys, how your bone marrow is functioning. We typically do a bone marrow biopsy to see if the bone marrow is involved with follicular lymphoma. And we do imaging. And the imaging could either be CT scans, or it could be PET scans, or it could be both. CT scans give you very good anatomy. PET scans tell you something a little different. When you get a PET scan, they inject some radioactive sugar into the vein, and the sugar is preferentially taken up inside cancer cells. And when you look at a PET scan, you see bright spots. And now with technology, we can integrate the CT scans and the PET scans and get these very fancy images that show the anatomy plus the spots as being bright or not bright. So very powerful technology to see where the cancer is, and then it's even more useful after treatment to make sure it's gone. Once we've done all that, we can assign a FLIPI score to a follicular lymphoma patient, which looks at, can we go back, thanks, which looks at 5 risk factors, and the more these risk factors a patient has, the worse the follicular lymphoma is in terms of prognosis, the fewer the better. So being over 60, having stage 3-4 disease, anemic, which is a hemoglobin less than 12, a high LDH, that stands for lactate dehydrogenase, or more than 4 involved nodal sites. And 0 to 1 of these things means you're low risk, 2 means intermediate risk, 3 or more means, quote, high risk. And then you can see the distribution, the different 5-year and 10-year overall survival. These are estimates for a population. And don't burn these numbers into your brain, because this data was generated on patients who were treated 10 and 15 and 20 years ago. So to be honest, these numbers don't even apply anymore. But we can still give a patient an idea of what category they're in if they want to know. To be honest, where this is most helpful is when the doctors are trying to evaluate studies in literature, because it tells us what kind of patients went on to the study. Because you could pick a treatment and you could put a bunch of patients with low or intermediate risk FLIPI on, and you'd get one set of data, and then you could pick the exact same treatment, and the study could have a bunch of high risk FLIPI patients, and the data won't look so good. And if you don't know what the FLIPI risk distribution is, you would think that it was because of the treatment, but it wasn't. So that's where doctors can get faked out if they don't know what kind of patients go on a clinical trial. So that's where this is most useful. Okay, so I already said this, the disease is generally incurable, but the prognosis is generally good and improving. And there are so many good treatments for follicular lymphoma, it actually makes the decision making very difficult. And that's a good problem to have. So when I see a new patient in clinic with follicular lymphoma, my simplistic brain breaks it down into 2 a 2-by-2 table. The first thing I want to know is, does this patient have symptoms, yes or no? Because if they have symptoms, we should treat them because we have good treatments that work and the treatments will make them feel better. It'll make their symptoms go away. So when they have symptoms, the decision making is relatively easy. We need to start on some kind of treatment. We just have to settle on what kind of treatment. If the patient has no symptoms, then the next thing to figure out is what is the tumor burden. And I think the tumor burden is more important than the stage, quite honestly. So the way I explain this to patients, this tumor burden concept, if we took all the cancer cells out of your body and made a pile, how big would the pile be? And high tumor burden has different implications than low tumor burden. Now we have some criteria for tumor burden. These are called the Guelph criteria, and these are reasonably useful criteria. 3 nodes bigger than 3 centimeters, a single node bigger than 7 centimeters, symptoms, risk of organ compression from the lymphadenopathy, a leukemic phase, which means the follicular lymphoma cells are circulating in the blood. If we see the blood counts dropping due to bone marrow involvement by the follicular lymphoma or a spleen above a certain size, if a patient has any one of these things, they would fall into the high tumor burden category. So my job today is to focus on the low tumor burden population, which is the upper left box. And there are a lot of newly diagnosed patients who fall into this box. So I'm going to focus on that group of patients now when we talk about management strategies. And what I said in the box here is, in my mind, the general approach is we either do watch and wait, and I'll explain why, or I think some patients are candidates for treatment with rituximab as a single agent. I personally generally do not administer chemotherapy to this group of patients at diagnosis. Well, why? Well, there have been 3 randomized clinical trials generated in the literature over the years, which took this group of patients, this low tumor burden asymptomatic group of patients, and they enrolled them in a study, and half the patients started out on immediate chemotherapy, and the other half the patients started out on this strategy of just close observation, or so-called watch and wait. And then their treatment would be initiated when it had to be. In other words, the patient then developed high tumor burden at some point, or they developed symptoms at some point. That's when their treatment would be initiated. This is very counterintuitive for a newly diagnosed cancer patient. You're going to watch me? Are you out of your mind? So half the patients are starting on immediate treatment, half are not. With all 3 studies, if you look at the proportion of patients alive, at 5 years, at 10 years, at 15 years, it's identical. There was no survival advantage for the patients who started on immediate treatment. It didn't hurt them either in terms of the survival. The survival was the same. But the patients starting on immediate treatment, which was chemo, presumably have some detriment in their quality of life for starting on chemotherapy. So based on that, the paradigm of starting folks initially on watch and wait was born. And that is the standard. That is what is typically done in the world for this group of patients. Now, having said that, all of these trials were done in the pre-rituximab era, the 1980s and the 1990s. Rituximab came around in the late 1990s. And rituximab has been a big difference maker for follicular lymphoma. But there has never been a trial of rituximab plus chemotherapy versus watch and wait. Such a trial has never been done, so we don't know what the outcome would be in that kind of a setting. We have no data to guide us. And to my knowledge, there is no trial planned. Matthias, do you know of any trial planned for that? Very hard study to do, and you can imagine why. If you're a newly diagnosed patient and you're going to be randomly assigned by a coin flip, watch and wait, chemo. You know, folks don't like that, which is understandable. It's a hard thing to do. It's a hard study to conduct. It's a hard study to execute, and it takes years to collect the data. It's a hard study to do, so we don't have that data. There is now one trial of rituximab as a single agent, no chemotherapy, just rituximab versus watch and wait, that has been presented at a national meeting. It's still not published, but I'm going to show you a little bit of data from that study to show you what immediate treatment with rituximab can do. This was the study. It was done by a group in the United Kingdom with some help from some other countries, Australia, Turkey. It was a randomized clinical trial, which means patients were assigned to one treatment or another. And it had 3 arms, or 3 different pathways that a patient could go on. So the top arm, I do have a pointer. Okay, so the top arm, patients, a third of the patients were assigned to watch and wait. A third of the patients were assigned to rituximab for 4 weekly doses, which is the typical way we give that drug. And then no further treatment, just observation. And then a third of the patients were assigned to rituximab for 4 weekly doses plus so-called maintenance rituximab, where you receive a single dose every 2 months out to 2 years. So this is, we call this induction, and then this is the maintenance part when you get the rituximab on an ongoing basis. After a while, they stopped the enrollment. They stopped the enrollment to the middle arm, the arm B. Next slide, please. Okay, so now you probably know that we cancer doctors are crazed about Kaplan-Meier curves, and I apologize, but this is a Kaplan-Meier curve, and this tells us how the population does over time. So let me explain this graph to you. The black bar is the patients who started on watch and wait. The red bar are the patients who receive rituximab for 4 weekly doses, no maintenance. The green bar are patients who received rituximab plus maintenance. And everybody starts out with their cancer not growing at time 0. And progression means the cancer is now growing. And every time a patient's cancer grows, the curve drops down. So what you can see here is the patients who received rituximab, here's 2 years out. About half the patients had had their cancer progress by 2 years in the watch and wait arm. And far fewer numbers had had their patients progress if they received rituximab. So we call this progression-free survival, survival without progression. So rituximab improved the progression-free survival. But to be honest, that is no surprise. You're giving patients some treatment versus no treatment. So we knew this was going to happen. We just don't know what the magnitude of the difference is. So it's useful information to tell us what the difference is, but we knew this was going to separate these curves. The next thing they looked at, time to initiation of new therapy. And this is the time it takes to move on to your next line of treatment, whatever that treatment is, chemo, radiation. So here's the watch and wait group. Here's the groups that received rituximab times 4 induction. Here's the maintenance arm. So again, it took longer to move on to another line of treatment if you started out on rituximab. At 3 years, over half the patients in watch and wait had moved on to some kind of treatment, and most of the patients on rituximab had not. So there's clearly a benefit in delaying your time to your next treatment. Again, not a huge surprise. These people have already had 1 line of treatment. These people have had 0 lines of treatment. So that's kind of a predictable result also. Okay, here's the overall survival. This is the probability of being alive at 2 years, at 3 years, at 4 years. There is no difference, as you can see. So once again, to date, there is no detrimental effect for watch and wait in this population in terms of your likelihood of being alive at 2 years, 3 years, 4 years. You with me so far? Okay. So what do you do with this information? This is a struggle because you can see there are some benefits by some endpoints, and by other endpoints there are not benefits, like overall survival. So if you want to improve the progression-free survival and the time to next treatment, rituximab does that. If you want to improve the overall survival, it does not. It gets down to the question of what endpoints really matter. And I'm kind of the opinion that only an individual patient can tell me that, because I think the answer will be different from person to person. There is this issue of quality of life then. And because these patients are asymptomatic, it's not an issue of symptoms or how you feel, it's a psychological quality of life issue. And how much benefit is there psychologically from being in remission, which rituximab can do, versus not being in remission if you're in the watch and wait arm? And these investigators tried to sort that out. So they did this thing called quality of life assessments in the vast majority of the patients. And they looked before and after randomization, 1 month, every 2 months, for 2 years, every 6 months, patients would fill out these questionnaires. These are the tools that they used. I don't want to spend much time on this. The point is, it all focused on depression, anxiety, and coping. Those are the issues that we're trying to capture with these scales. I think that's just repeats what I said already. What you really want to see is, can you go back one slide? What you're really trying to see is, does the immediate treatment with rituximab result in increased functional well-being? That would be a global term that encompasses the anxiety, depression, and the coping. Functional well-being. Okay, next slide. Okay, so it turned out that there were a minority of patients that suffered from anxiety and depression. 13% anxiety, 3% depression. So that's a significant minority, although most did not. Patients assigned to rituximab had less anxiety and depression than those on watch and wait. So there was some benefit for rituximab, but most patients functioned very well, and most patients, whether you got rituximab or watch and wait, adapted to their illness over time. And I guarantee you, Stephanie will tell you that she sees this in her practice all the time, that people are super uncomfortable with watch and wait, but over time, they adapt to it. Not everybody. Some people don't, but many do. I've had some people who were practically ready to fire me when I said watch and wait. And then 4 years later, when I said it's time to treat, I had to drag them into the treatment room kicking and screaming. So, I mean, folks can really change mentally their adaptation over time. So here are my conclusions. Given the lack of overall survival difference, it remains perfectly acceptable to do watch and wait. And that's generally where I start the conversation with the patient. There are some benefits to rituximab as a single agent in terms of progression-free survival and time to next treatment. And I discuss these with the patients. We go over all this. And for a minority of patients, they do have significant anxiety and coping issues with watch and wait. And it actually really detracts from their quality of life significantly. And I think for this group, rituximab has real benefit. And so I try hard to ascertain who these folks are. And for those patients, some patients, maybe 15, 20% of my population, I will start them on rituximab for this issue. Hopefully that makes sense. Okay. Stephanie mentioned this trial, RESORT, ECOG 4402. This was this trial we did in the Eastern Cooperative Oncology Group, and it was in this exact same patient population, this low tumor burden asymptomatic patient population. Kind of a confusing study to understand, so I'm going to try to spend just a minute on that. But everybody started out on rituximab, and if they responded, which turned out to be 70%, 7 out of 10 patients would go into remission after 4 weekly doses of rituximab. They would then be randomized, and half the patients received rituximab as a maintenance strategy with no stop date. As long as the drug is working and as long as you want to keep taking it, you can stay on it. So there have been people on maintenance on this study now for 5, 6, and 7 years. Versus retreatment, which would mean you get your 4 weekly doses and then we go into observation mode. And we just watch that group of patients very closely. And once we see progression on a CAT scan or by physical exam, lymph nodes starting to grow again, we will retreat you with 4 weekly doses, try to put you back in remission, and then we will take our hands off you again. And then just start watching you. And do it all over again. And you could keep doing retreatment as long as it's working. So it's an issue of getting ongoing predetermined rituximab versus as needed rituximab. And the main endpoint was time to treatment failure. Basically, when does the rituximab stop working for you? So I'm just going to give you the bottom line. We presented this at a meeting last year. This was a study that took a long time to do. There was no difference between the two treatment strategies and the time to treatment failure. Same result. It was a tie. If you look at time to first chemotherapy, the maintenance was a little better. At 3 years, 95% of the maintenance patients were chemo-free, had not moved on to chemo, versus 86% of the retreatment patients. So small benefit there. Although it came at a cost. It took 3.5 times, there was 3.5 times more rituximab used in the maintenance population to get this result, to get the tie for this and the slight benefit for this. Both arms were well tolerated, actually, but there was a little more toxicity on maintenance. So I promise you, we stared at this data for a long time, trying to figure out how we wanted to interpret it and what message we wanted to give. But we finally concluded that we thought that retreatment was our recommended strategy if using rituximab in this patient population. That's because there was a tie for the primary outcome, a small benefit for this outcome at the cost of a lot more drug. I should mention no difference in overall survival. Okay, the overall survival is equivalent. A lot more drug used, a little more toxicity. I'm not saying maintenance is bad or wrong. This was like a close call. But between the two strategies, if I see a patient with low tumor burden follicular lymphoma and we don't do watch and wait and we do start on rituximab, I recommend the retreatment strategy to them based on this. Okay, so here are my conclusions. Low tumor burden follicular lymphoma, this means the disease is asymptomatic and there's a low disease burden. Watch and wait is a very commonly used strategy. If your doctor recommends this, they're not crazy. This is based on old data and we admit that. And we don't know what rituximab and chemo together will do for this patient population. It's unclear. Rituximab as a single agent has been shown now to delay the time to chemotherapy, but has not shown an impact on overall survival. It does improve the quality of life for a minority of patients. Using a maintenance strategy versus a retreatment strategy results in very comparable outcomes. And so both are reasonable. I prefer retreatment for this patient population. And that's where there's my office right there. I did not get the 7th floor, I got the 4th floor. I clearly need to improve my stature at that place. I'm working at night, so anyway, at this point I would be happy. I don't know how much time we have.
Thank you very much. We do have time. We have time for a few questions. Please. And if you can come to the microphone, that would be wonderful. Thank you. Yes.
Yeah.
Go ahead. Go ahead, please.
Rituxan treatment and rituximab is the same?
Yes, Rituxan and rituximab is the same drug. I made an assumption that most people knew what this drug is. I hope that was correct. If you don't, rituximab is a monoclonal antibody, which means it's a protein. It's not a chemical like chemotherapy. It's infused into the veins intravenously. It circulates through the blood. It will stick to the outside of the lymphoma cells. It will coat the lymphoma cells. And when it does that, it tries to trick your immune system into coming and killing the cancer. And that's how the drug works. There's no nausea, there's no vomiting, there's no hair loss. It doesn't have a lot of the bad things we think of with chemotherapy. So from a side effect and toxicity profile, it's an attractive drug.
Yes, hi, I'm Melanie. My question is, the Affordable Care Act, how does that impact the overall survival rates, and will that impact whether you get drugs or not based on whether they're effective or not in the long term?
I don't see the Affordable Care Act impacting the way we are able to practice medicine at all. I don't see it affecting us in a negative way at all. I have no worries, no concerns about that personally. One of the things that the federal government is very interested in is this thing called comparative effective research. You might have heard that term. Actually, the resort trial is a decent example of that. There was an assumption that maintenance was better, and lots of drug is being prescribed with unclear benefit, and I think we just showed that you can give a lot less drug and save a lot of money societally with comparable outcomes. So I think the resort trial is a pretty good example of comparative effective research.
Yes. My name's Larry, and I
Yes.
have two questions actually. The first one was on the Guelph criteria for the high tumor burden.
Yeah.
And you said any one of the criteria would qualify somebody as high tumor burden. And one of those criteria was the systemic symptoms or any symptoms. Could you kind of give more details on what that would involve?
So the most common symptoms for a lymphoma patient would be fevers, night sweats, weight loss. Those are so-called B symptoms. Sometimes people will experience pain from enlarging lymphadenopathy. Another symptom sometimes people will report is fatigue, and that is a tricky one, trying to decide if the fatigue people feel or experience is from their lymphoma or not. You really have to drill down with patients on that one. I've had patients in clinic and they're like, oh, I'm so tired, this has got to be this follicular lymphoma, and I'll say, give me an example. I'm like, are you able to do your job? Oh yeah, I work 2 jobs, I work 16 hours a day. I only get about 5 hours of sleep a night. I got 3 kids in school, soccer, football, da-da-da-da-da. And I just have no energy after all that. So, you have to sort that out before you ascribe the fatigue to the lymphoma.
Great, thank you.
Yep.
And the second question had to do with the no trials of our chemotherapy in the population for the low tumor burden and asymptomatic. Is there any anecdotal evidence, since patients even in that category can, based on patient preference, be treated? So has there been experience where doctors have kind of observed anything?
It's a great question. The question is about our chemo in that patient population. I typically don't do it. And the problem with the anecdotes is these patients do very well, no matter what you do. And so if you do an our chemo trial, or if you do a couple anecdotes in your practice, those patients are going to do fabulous, but they would have done fabulous with other strategies. So the real question is it better than what you otherwise could have done? So I don't have any useful answer for that question. Maybe some of the other speakers will.
Thank you.
Yeah.
Yes, my question is, you were talking about how you would treat a newly diagnosed person presenting themselves with asymptomatic and low tumor burden.
Right.
What about somebody has the same characteristics but has had lymphoma for 15 years?
Right. Someone who's had some treatment or has never had treatment.
Who has had maybe minimal treatment, in other words, they've had Rituxan,
Right.
and maybe they've had radiation also.
Sure.
But would they be a good candidate for, would the Rituxan maintenance be different for them, or the retreatment option, which would be better for them?
Yeah.
Is there a difference?
Well, we don't know for sure. In general, the same rules apply. So there's a huge population of follicular lymphoma patients who have had some prior treatment, whose disease has now come back, but they are asymptomatic with low tumor burden. All the same rules apply. Everything I just said, I believe, applies to that patient population. You can do watch and wait. You can do treatment. All of these treatments have a high likelihood of working. You could do rituximab. You could do it as a single agent. You could do it as maintenance. It's the exact same thought process to everything I just described. You have all those options. And we don't think that jumping in with an early intervention for that second, to induce the second or third remission, changes the overall survival. So we will typically watch and wait those patients until the disease advances to a point where treatment is indicated.
Okay, thank you.
Last question, thank you. Okay. This is not really a question. I'd just like to share with you my experience of being asymptomatic. As I was diagnosed in August of last year with non-Hodgkin's follicular lymphoma. 5 months prior to that, I had blood work done for an outpatient surgery unrelated to my lymphoma. My blood work was normal. My blood tests were normal. Showed nothing abnormal at all.
And that's typical.
Yeah.
Yep.
So I didn't have any symptoms until
Right.
2 months later when I had a lump in the side of my neck about the size of a marble,
Yeah.
which I just kind of like let it go until a few weeks later I had 2 on my collarbone, and then I knew I had.
Still watch and wait?
No, I underwent treatment. I had chemotherapy last fall.
Yeah. So one of the things that you will often see, it's always okay to start out on watch and wait. And you learn a lot by watching that individual patient over the next several months. Every patient is different. I cannot emphasize that strongly enough. And you have patients, you'll have no budging in anything for years and years and years. And then the next person you see, you started out on watch and wait, and they come back 3 months later, and everything's growing. And you got to change the plan. So it's always okay to start out watching, and you just adapt. And you change the plan based on what you're seeing before you. That is totally appropriate. Okay, thanks.
Excellent presentation.